Welcome to this video on Pediatric Cardiac Radiology in our series on Pediatric Radiology Education. My name is Mary Wyers, and this video will go through an introduction to pediatric cardiac imaging designed for the radiology resident. The classic approach to teaching congenital heart disease required a knowledge of whether a patient was cyanotic or acyanotic, an assessment of heart size, and whether the pulmonary vascularity was increased or decreased. This led to a chart-like approach in memorizing lists of different conditions based on these features. However, there were many problems with this approach. Many congenital heart lesions did not fall neatly into these categories and were difficult to assess in the neonate. Instead, this video will go into a discussion of the chest X-ray in imaging congenital heart disease, as well as an introduction to assessing three main components with examples: the heart size and contours, the great vessels, and the pulmonary vascularity, and how congenital heart disease with altered anatomy and physiology may affect these features. We will begin with a discussion of the utility of the chest X-ray. There are some problems with using a chest X-ray to diagnose or screen for congenital heart disease. Some congenital heart diseases are complex, with an association of multiple abnormalities, leading to a confusing chest X-ray picture. Patients are often diagnosed earlier and do not have time to develop classic chest X-ray findings. In the first few weeks of life, there is a normal physiologic pulmonary hypertension which remains from fetal life. This means that lesions which may typically cause increased blood flow to the lungs, such as left to right shunts, will not be visible on a plain film until later when the pulmonary vascular resistance drops. Also, the ductus arteriosus is open at birth and can result in mixing of blood flow in lesions that may otherwise have obstruction to blood flow. For example, this newborn with hypoplastic left heart syndrome does not have significant findings of left heart obstruction yet by plain film, due to mixing of blood by the ductus. Finally, the technique itself may be limiting. Neonatal chest X-rays are typically done with supine AP technique, and the presence of the thymus and variable lung expansion will contribute to the limitations. Several studies have been done to demonstrate the limitations of chest X-rays in congenital heart disease. In one study comparing chest X-rays with echo, the researchers found the sensitivity for detecting cardiac enlargement was only 59%. The specificity was better at 92%. In a separate study assessing how accurate pediatric radiologists were in determining whether a patient had congenital heart disease based on a chest X-ray, they found an accuracy of only 78%. When asked what the specific congenital heart lesion was, the accuracy fell to only 71%. So what is the use of the chest X-ray in pediatric heart disease? It can be useful as a general overview of how severe a process is, or whether there is an acute change such as pulmonary edema. It is used for preoperative evaluation and in the immediate postoperative time period, as well as for routine follow-up and for assessment of major changes. But it is not typically used for screening or to make a specific diagnosis, which is done by echocardiography. CT and MR have an increasingly important role in pediatric cardiac imaging. They are able to assess the severity of disease and answer specific anatomic questions, such as how tight a stenosis actually is. They are able to look for associated abnormalities and for a more complete picture of all the vessels in the chest, some of which may not be well seen by echo. And finally, they can be useful for postoperative follow-up, to look for new problems, assess function, or confirm patency of shunts, for example. We will move on to a discussion of how anatomy and physiology affect imaging, first regarding evaluation of the heart itself. It is helpful to be familiar with the shadows on a chest X-ray caused by the normal cardiac chambers in order to detect enlargement or changes. For example, you will note that the posterior borders on a lateral chest X-ray are comprised of the left atrium and the left ventricle. With this knowledge of anatomy, we can often see examples of specific chamber enlargement. In this patient with tetralogy of Fallot, the right ventricle is hypertrophied and enlarged, seen here on the lateral view anteriorly, and leading to an upturned apex on the frontal view. Cardiothymic silhouette enlargement is often nonspecific by chest X-ray. Here are several examples of different entities leading to enlargement: congenital heart disease, heart failure due to high output from a peripheral AVM, a pericardial effusion, and a mediastinal mass. The lateral view is sometimes considered to be more accurate in determining true cardiac enlargement due to the presence of the thymus and other technical factors. Here is a patient with restrictive cardiomyopathy. While the frontal view may suggest a prominent heart size, the posterior bulge of the cardiac border is readily seen on the lateral view, and allows the radiologist to be more certain in suggesting cardiomegaly. Besides cardiac size, we should also assess the position of the heart. This is one component involved in determining the situs of the patient, which is too complex to completely determine by radiography. On the left is normal situs, with a left-sided cardiac apex and a left-sided stomach. Situs inversus is a complete mirror image of this, although true situs inversus is actually rare, and while the stomach and cardiac apex may appear to be right-sided, as in this case, true determination of situs must also include an assessment of atrial morphology, bronchopulmonary anatomy, and visceral location and morphology. And finally, situs ambiguous or heterotaxy, which is any other combination. In this case, the cardiac apex is left-sided, but the stomach is right-sided. Cross-sectional imaging allows a more morphologic or segmental approach to assessing the heart. The segmental approach requires the imager to assess three components, the atria, the ventricles, and the great vessels, and to ask several questions. How are they connected? What are the associated anomalies, and how do they function? Here is an example of atrioventricular discordance, where the left atrium is connected to the right ventricle. The chamber morphology of the left and right ventricle is well assessed on CT and MRI and should be used for accurate assessment of the chambers, which may have altered position related to congenital heart disease. The right ventricle is normally anterior and has a moderator band, which is a muscular connection between the septum and the free wall. The right ventricle also has a conus or infundibulum, which is a muscular band of tissue separating the pulmonic and tricuspid valves. Here on the right is an example of a moderator band within the right ventricle. The left ventricle is normally posterior and has no moderator band or conus. Next, we will move on to a discussion of the great vessels. The aortic arch can often be well seen on a chest X-ray in an older patient. In younger patients, it is more challenging, especially in the presence of the thymus. Therefore, you should always look at the position of the trachea on a frontal chest X-ray. It should be a non-rotated film, and the trachea should be slightly to the right, as in this normal case, since the left arch will deviate the trachea a little bit rightward. A right aortic arch, on the other hand, will deviate the trachea to be more midline, as in this example. On cross-sectional images, the position of the great vessels should always be assessed. The normal main pulmonary artery should be located anterior since the right ventricle is anterior, and to the left of the ascending aorta. Transposition of the great arteries is a good example of abnormal great vessel position, where the aorta is anterior to the pulmonary artery since it is arising from the right ventricle. With classic D or dextrotransposition, the aorta is to the right of the pulmonary artery, and with L or levotransposition, the aorta is to the left of the pulmonary artery. Finally, the contour and the size of the great vessels should be assessed. On this chest X-ray, if we follow the contour of the aorta, we see a subtle indentation, and this patient had aortic coarctation. Here is an example of abnormal great vessel size. This patient has marked bilateral hilar enlargement due to enlarged main and left and right pulmonary arteries due to absence of the pulmonic valve. Lastly, we will move on to a discussion of pulmonary vascularity. Assessment of pulmonary vascularity has always been taught as an important concept in imaging congenital heart disease. However, visibility of increased pulmonary arterial vascularity can only be seen when flow through the lungs is doubled. It may also be difficult to tell the difference between the increased pulmonary vascularity related to a shunt lesion and the prominent venous vessels due to pulmonary edema. Finally, any asymmetries between the left and right side and presence of any abnormal vessels should be assessed. Here is an example of increased pulmonary vascularity due to enlarged pulmonary arterial vessels or shunt vascularity. This is due to a patient with a left to right shunt related to an aortopulmonary window. If we look at the more peripheral aspect of the lung where we expect the pulmonary vessels to taper, we can see that there are too many vessels here and they are larger than normally seen. Here is an example of decreased pulmonary vascularity in a patient with Ebstein's anomaly, a malformation of the tricuspid valve, associated with right heart failure and usually a right to left shunt through an ASD, leading to less pulmonary blood flow. Distinguishing enlarged venous vessels related to pulmonary edema from enlarged vessels of shunt vascularity can be difficult. With pulmonary edema, the vessels are more hazy and indistinct. Findings may be similar to a viral infection, adding to the difficulty. Cardiac enlargement related to venous edema may also be disproportionate and more prominent than the vascularity changes in pediatrics. Other findings such as curly B lines and pleural effusions may or may not be present. Here on the left is a patient with pulmonary edema. There is total anomalous pulmonary venous connection with obstruction of pulmonary blood flow back to the heart, leading to a small heart and hazy venous vessels with interstitial edema. On the right is a patient with shunt vascularity and a VSD, who has enlarged but better defined pulmonary vessels. Here is an example of asymmetric pulmonary vascularity. In this patient, it is increased on the left more than the right. This patient had an AV canal and had undergone a pulmonary artery banding procedure. The pulmonary artery band had slipped, leading to more restriction of flow on the right and greater flow on the left. This is an example of asymmetric vascularity by CT. This is a 6-year-old patient with right pulmonary vein atresia. No right-sided pulmonary veins enter the left atrium. On lung windows, you can see the associated venous interstitial edema on the right. Finally, here is an example of an abnormal vessel. This patient has a smaller or hypogenic right lung with shift of the mediastinum to the right and an abnormal vessel seen here behind the heart. This patient has scimitar syndrome, and this vessel represents partial anomalous pulmonary venous return. On the lateral view, there is a characteristic line seen along the anterior aspect of the chest in this syndrome due to the smaller right side with shift and rotation of structures, creating this interface on the lateral view. Thanks for watching, and I hope this gives you a good solid introduction to imaging heart disease in children.